To plan eye care services for people with diabetes, we need to know the incidence of diabetic retinopathy, new cases, in our population. That is, how many people with diabetes will develop diabetic retinopathy during a specified time period. There are three main steps to measure the incidence of diabetic retinopathy. 1. We use an agreed case definition and assessment method to define what is and what is not diabetic retinopathy. For example, we can use the International Classification of Diabetic Retinopathy and Diabetic Macular Edema, and simple single-field 45-degree digital imaging. 2. We select all the people in a defined population who have diabetes but do not have visual impairment from diabetic retinopathy. That is, they are disease-free. And 3. We then follow this group, sometimes known as a cohort, for a specified time, for example 10 years, and measure who develops diabetic retinopathy during that time. To date, most of the population-based incidence studies on diabetic retinopathy, or DR, have taken place in high-income countries. Variations found in this data have highlighted that the risk factors for the development and progression of DR can be divided into non-modifiable and modifiable factors. Public health interventions to prevent vision loss from DR need to include a screening policy to target those at increased risk and provide health education to minimise that risk. Non-modifiable risk factors for DR cannot be influenced or changed. Duration of diabetes is a single major risk factor. The longer a person lives with diabetes, the higher the risk of developing DR. The cumulative incidence of DR in people with type 1 diabetes has been found to increase from 59% at 4 years to 89% at 10 years to 97% at 25 years. The cumulative incidence in people with type 2 diabetes has been found to increase from 26% at 4 years to 66% by 10 years. A decline in the incidence of DR has been noted in some settings after improvements are made to the health management of people with diabetes. Age. Growth spurts, hormonal, dietary, and other changes in the post-puberty period mean that teenagers who have type 1 diabetes have a 30% increased risk of developing diabetic retinopathy, and this risk is even more significant in males. Pregnancy for a person with diabetes carries a 50% risk of developing diabetic retinopathy. In women who already have non-proliferative DR, there is a 47% chance of the disease progressing to a severe stage, and up to 50% of those will require laser treatment. Although 29% of women with DR experience regression of the disease in the postpartum period, pregnancy remains a high-risk event. Based on the trends found in DR incidence studies, genetic predisposition and ethnicity have drawn considerable interest as possible non-modifiable risk factors for DR. Some patients are also predisposed to severe diabetic retinopathy, even with adequate control. Modifiable risk factors can be controlled through medication or change in behaviour. There are several associated, known and possible modifiable risk factors for DR. Blood glucose control, blood pressure control, blood lipid levels, body mass index, and smoking. Blood glucose control is measured through the glycated hemoglobin, or HbA1c test. Clinicians measure HbA1c levels to get an overall picture of what a person's average blood sugar levels have been over the past 2 to 3 months. The ideal HbA1c level in a person with diabetes is 48 millimoles per mole, 6.5%. Evidence shows that for every 1% reduction in HbA1c, there is a 40% reduction in risk for the development of the microvascular changes of diabetic retinopathy. On a practical level, this 1% reduction means a 25% reduction in the need for laser treatment and a 15% reduction in risk of blindness. Intensively maintaining levels of blood sugar as close to the ideal as possible, known as good glycemic control, right from diagnosis is very beneficial for people with diabetes, both in preventing diabetic retinopathy and in delaying the progression of any disease that does develop. People with diabetes often also have high blood pressure, hypertension. The incidence of visual loss in people with type 2 diabetes is higher when they also have hypertension. Reducing systolic blood pressure by 10 millimeters of mercury results in a 35% risk reduction for developing diabetic retinopathy, a 35% reduction in the need for laser treatment, and a 50% reduction in risk of blindness. Controlling hypertension has been found to have an effect on reducing the incidence of DR. Excessive levels of fat or lipids in the blood is called hyperlipidemia. Hyperlipidemia and obesity are associated with DR, but the evidence so far is limited on whether they are risk factors for the disease. Use of the drug Fenofibrate to reduce cholesterol levels has been found to reduce the risk of requiring laser treatment for proliferative DR. The data varies on smoking as a risk factor for progression of DR. Some studies have found no association, whilst others have. Experimental studies have noticed that nicotine accelerates diabetic retinopathy. Finally, it's important to note that diabetes is associated with early and rapid development of cataracts. Progression of diabetic retinopathy has been associated with cataract surgery. Where possible, preoperative blood sugar control is required and existing retinopathy stabilized with laser treatment before surgery. When removing dense cataracts, there should be close follow-up and management of any diabetic retinopathy progression. In summary, research has revealed that there are modifiable and non-modifiable risk factors for DR. Control of blood sugar level is the most important modifiable risk factor for reducing the progression of DR. Controlling all the modifiable risk factors for DR is vital and must be considered along with reducing the risk of other complications of diabetes, for example, kidney or heart disease. Physicians and ophthalmologists need to work together to manage people with diabetes over the long term.